Everyone will get started in just a second as people settle into their Zoom boxes here. You're at the Silver Hill Hospital Grand Rounds program. All right, welcome everybody. I am Dr. Jeff Katzman, the Director of Education here at Silver Hill Hospital, and we are absolutely delighted to have you with us today. We are privileged to welcome one of our own, Dr. Ryan Wade, who will be presenting on the topic of stigma and substance use disorders, and I will have the pleasure of introducing him in just a moment. First, I will go through some housekeeping details. I had sent a note actually to Silver Hill Hospital staff that needs a bit of correction. This is actually our penultimate grand rounds for 2022. Our final lecture is not today, but on Wednesday, December 14th, with Dr. Mark Fry presenting Emerging Discovery to Innovate Beyond Best Practice for Bipolar Depression. You can sign up for that via the invitation or on our hospital website calendar under Education and Resources. For today's lecture, if you wish to receive education credits, CME or CEU, please kindly complete the evaluation survey that will pop up in the browser when the webinar ends. We will also email a copy of the evaluation after the webinar concludes. As always, I'll moderate a Q&A discussion with Dr. Wade at the end of his lecture. Questions really remain a very important part of our grand round. So please use this opportunity to put forward questions and comments to Dr. Wade. You can submit a question anytime using the Q&A box, either with your name or if you prefer, you can submit it anonymously. And finally, disclosures. No planners of this activity have indicated a relevant financial relationship with an ACCME defined ineligible company whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. It is now my great pleasure and honor to introduce our guest speaker today, Dr. Ryan Wade. And I want to start this by saying Dr. Wade is an outstanding clinician who we all look up to here at Silver Hill with expertise in addiction. And for me, as a director of education, he has been really just the primo resource and teacher for so many of our different learners, right? And just a public appreciation for everything that Dr. Wade is doing for us here and for me in developing an education program here. A bit about Ryan. He is a board certified psychiatrist who earned his medical degree from and completed a general psychiatry residency at Eastern Virginia Medical School, followed by completing an addiction psychiatry fellowship at Yale University School of Medicine, where he was the first fellow to train primarily at the Connecticut Mental Health Center, CMHC, position funded by a Health Resource and Services Administration grant. While working with CMHC, Dr. Wade developed an addictions education seminar with presentations and discussions held monthly for CMHC staff to support addiction education, advocacy for persons with substance use disorders, and to reduce stigma related to addiction. Dr. Wade is currently the lead psychiatrist for the dual diagnosis transitional living program at Silver Hill Hospital, in addition to maintaining an academic appointment at both Eastern Virginia Medical School and the Yale School of Medicine. Dr. Wade also serves as medical director for multiple telehealth startups and as a collaborative physician for several psychiatric mental health nurse practitioners. So with that, I am very honored to have this opportunity to, Dr. Wade, turn the baton over to you, and thank you again for joining us and sharing your wisdom. I'm going to go dark here for a moment, and please everybody remember to put in Q&A as we go along, and then I'll rejoin in the last 20 minutes or so, and we'll have a conversation. Thanks.
All right. Well, thank you for the kind introduction, and thanks everybody for your time today and joining us here. And so we'll be discussing stigma and how it influences substance use disorders, kind of the history of how this develops and things that we can do and working with our own language and the way we're working with folks to try and reduce stigma and these sorts of biases. First, I have to disclose that I don't actually have any financial relationships that would taint this presentation. Unfortunately, no one is paying me to do this, so it's a free hour for y'all. Objectives of the presentation: we want to make sure that folks have a better recognition of stigma and the effect it can have on our patients with substance use disorders and working with addiction. We'll spend a little time exploring our own personal views on substance use disorders and some resources trying to identify our own biases and have some more insight into ourselves and how that affects our view on these things. And then we'll work on identifying stigmatizing language relative to substance use disorders and addiction, and how we can communicate using more person-centered terminology that can help us to connect with these folks a little better. And so just a brief order of events, we'll discuss stigma specifically in the historical review of how it developed, and then things like criminalization and policy changes government-wise, how these can affect perceptions and affect the way we deliver care. That tends to have a large impact on this sort of thing. And then what we can do on an individual level in our own day-to-day interactions with folks. So we'll start with defining stigma. It's in general, it's a mark of disgrace, like the traditional definition of it being a mark of disgrace associated with particular circumstances, qualities in a person, or about a specific person. When we look at it related to health conditions, it describes more, the quote here on the screen, it describes more of a sociocultural process in which some groups are devalued, rejected, or excluded from treatment, or receiving inferior or subpar treatment on the basis of a socially discredited health condition. And that's kind of where a lot of this comes from in looking at stigmatized populations. And there's been a lot of focus on that in the general population in the last couple of years in terms of putting more of a focus on minority groups and those that are stigmatized for racial, cultural, religious sort of persecutions. Though this can happen within healthcare and different health conditions as well. And so there are a few types of stigma that we tend to see. And we may not think of all of these things as stigmatizing, though. Boiling down these sorts of views, any of these can be stigma in and of themselves. Any of these can cause bias. So self-stigma, it's more of a subjective process that would be characterized by negative feelings about oneself, or some maladaptive behaviors, or things that we have perceptions of ourselves that may lead us to anticipate negative social reactions on the basis of what we think society would perceive. So this picture here demonstrating a female looking in the mirror, seeing herself in the reflection as someone that's overweight or fat, when in the reality is not that, when you see her standing next to the mirror. And in the way that we perceive ourselves, we can almost be more discriminatory or devaluing to our own self-worth, and that can affect how we interact with others. Social stigma is something we're all a little more familiar with. It's where you have large sort of social groups, really reinforcing stereotypes or beliefs about a specific group, and acting in a certain way that kind of proliferates that. And so, we see this when we have like, boycotts, or we have people making, riots also would be an example of that. But we have this sort of polarizing view within a social group directed towards another social group based on particular characteristics. And so the example in this picture would be referring it to those with the religion of Islam, and how they're kind of characterizing them all along with the terrorist attacks of 9/11. And then the last, which actually has a good amount of influence into what we're talking about today, as does social stigma, though it's structural stigma. That's in reference more to rules, policies, um, you know, institutional procedures that end up restricting rights, opportunities, and they're stigmatizing a specific group of people. And so the previously, when we would have people taking public transportation, there had been, a policy about minorities or persons of color having to be in the back of the bus, right? And that's preceding the whole Rosa Parks sit off on the bus and everything. So we have this sort of structural policy that would lead to marginalization of those groups. And this is a rather clear and evident sort of stigma that was in place, though that's also kind of looking retrospectively. We actually have a lot of those things in place with government now that we don't necessarily recognize or aren't as clear, because they're not necessarily based on something as visible as the color of our skin. So how does stigma factor into substance use disorders? We actually see that persons with substance use disorders are the most stigmatized group within those within healthcare or groups that are associated with different health conditions. These sort of conditions are perceived as being, people that have a lot of control, like personal control over their condition and aren't exerting that control. There's an aspect of many substances that, they're still illegal, or there's something, immoral about utilizing the substance. And in general, when they're polling perceptions of these sorts of things, we see that illegal substances are more negatively viewed than legal substances. And as a society, we've defined these sorts of things as criminal, and that also influences kind of how we are perceiving those individuals, not just on the basis of the individual. It's the fact that the substance they're using is illegal, and so sort of devaluing, their place in society, their need for medical care, all of those sorts of things. People utilizing heroin are generally perceived as having more of a it's more disapproved or unapproved, I suppose I should say, sort of substance use as opposed to prescription opioids, for example. And there's a lot of morality that gets tied up in these sorts of things. And it's important to note, because it's not just the substance use disorder itself that ends up needing treatment. We often see substance use being associated with a number of other stigmatized conditions, behaviors, what have you. There's a lot of impulsive behavior or unsafe behaviors that we'll see within folks that are using substances. And, it can be something that leads them to use a substance. It can also be something that happens in the context of intoxication on a substance. And impaired driving would be, the most commonly recognized one. Though we also see things like mental illness, which all of us who work in this field understand that there is, still some stigma out there about mental illness and working with patients with psychiatric conditions. And, there's a huge concordance between substance use disorders and those with mental illness. There all tend to be, social problems, which can include criminal type behavior, with some of these substances being illegal. But we also see greater rates of substance use and substance use disorders within the homeless population as well. It's a lot of times it's associated with poverty. And depending on the substance that's used, there are several medical conditions which still have some social stigma to them. Hepatitis C, sexually transmitted infections, HIV, not necessarily as stigmatized as it had been a few decades ago, though still has some connotation to it. These are all things that we see in greater proportions with those that have substance use disorders. So, whether the substance use is contributing to those or just merely associated, we're seeing greater rates of these things. And so these are populations that are exceedingly likely to be marginalized, not only because of the substance use, but these other affiliated conditions. And so you'd think, with us being within mental health and the healthcare field, and you'd think we'd recognize these things and be a little more approachable, a little less judgmental about it. And it's actually not quite the case. You know, we see that there's a lot of negative opinion. There's a lot of frustration amongst providers in working with folks with substance use disorders. They are frequently perceived as overusing resources, you know, being a strain on the system in that way, or not necessarily being invested in their own care, or potentially, you know, sabotaging their own treatment, and frequently are referred to as non-compliant. And we'll get more into language in the later parts of the talk, but even something like non-compliant can be sort of derogatory phrasing. We generally prefer the term non-adherent. To have to comply would feel as if, you know, our recommendations for treatment or our what we're trying to have patients engage with would be almost like a rule or a policy that they're not complying with. When in reality, we come up with treatment plans and regimens that we would hope folks would like to adhere to. But referring them as non-compliant almost makes it seem as if they're breaking rules, so to speak. And it's common phraseology that we'd see within this population. And so there's even not unintentionally, we can have these sort of derogatory remarks or beliefs about patients. You know, and it's important because it can impact the quality of care delivered or the services that are even offered. You know, if feeling like the person's not invested in their care, or they're more likely to be a drain on the system, they're going to relapse, all these kind of beliefs can alter what we're offering to patients and what medical services we might provide them. And so what we see in those folks are, at some point or another, are still actually going to interface with the healthcare system, right? We all have healthcare needs at one time or another, and oftentimes it can lead to, you know, a sort of resistance or a hesitation to actually seek treatment. You know, they might come in for treatment, though, you know, conceal any sort of use or minimize the amount of use that they're reporting, so that they're not, you know, not reprimanded by their provider, or they're not, you know, things aren't just chalked up to the substance use before they're actually getting any sort of treatment for what it is that they're presenting for. You know, the idea of a lot of different types of treatment for substance use disorders, actually, you know, those perceptions influence people that might benefit from them, right? So that they may be more likely to refrain from treatment, or you know, I don't want to go to a methadone clinic, or I don't want to start Suboxone, I don't want to be on one of those medications because of, like, you know, the social perception of these sorts of things. You know, they're aware of the stigma out there, and then the stigma within the medical community, and not wanting to, you know, to seek out treatment or maintain treatment because of the way they might be perceived. You know, and we're getting much better about this, and much more understanding about what can be helpful in the treatment of addiction and conceptualizing addiction as a disease. So, you know, certain providers may withhold some treatment on the basis of stigma, and I see it all too commonly where, you know, someone that has, you know, a longstanding history of ADHD, their provider will no longer give them a stimulant for their condition because they've been abusing another substance, and even if this has been diagnosed in adolescence. And so there are certain aspects of treatment that providers may not feel as comfortable engaging with, given substance use disorders, and there is often increased liability in these populations. And you know, it's this sort of understandable, you know, line trying to tread. It's quite common within this population to see things like that, which you don't find a similar parallel with many other health conditions or mental health conditions for that matter. So effects that this can have on the people in particular, not just with relative to healthcare concerns. You know, people are more likely to be in isolation, feeling like they're an outcast from society, which you know they can then have impacts on really all aspects of their lives. You know, we wouldn't want, if we don't want anyone to know that it's going on, or having difficulty actually refraining from use, you're going to be withdrawn from not just social interactions, but you know, even attending appointments or going to work, those sorts of things. It leads to worse and worse care of ourselves. And honestly, if they do return to recovery or even try and reintegrate within society, I mean, it's delaying all of those efforts. And part of that ends up being they end up taking more risky behavior, taking on more risky behavior. One of the more tangible ones that we'd see would be those that are using IV drugs would be sharing a needle because they don't want to go to a needle exchange or go to a pharmacy or to try and obtain sanitary needles, and someone else that is using might be the only other person that understands. And so they would share a needle, even knowing that there's a lot of health risk tied up in that. They would do so feeling like they have nowhere else to turn. And probably the biggest one here is we do see people that would bow out of treatment or avoid treatment entirely just because of all the stigma. The perception of folks related to their condition and the treatment they're getting. They may avoid entirely entering treatment or just end up terminating treatment early or no showing appointments, not coming in. Any of these things, it can be really detrimental to care for their substance use disorder, and that's really the first step in getting the rest of their life back in line. It's really hard to manage all these other things with an ongoing substance use disorder. And so there's another side to stigma as well. We can take this perception of things and we can kind of use it, almost leverage it to our advantage in from a healthcare perspective. I have here a few different ads. We have the this ad on the left is a baby with toys all around him smoking, and the toys themselves are a little small. It might be difficult to see, but they're apparently lit cigarettes in each one of those little toys on the ground there. And the caption reads, "You don't need to smoke around them to kill them," insinuating that there's risk to the child if there's secondhand smoke, and oftentimes even not smoking in the room with the child, there's still things around the room or like the clothing or what have you can actually still have smoke present, which to a baby that's small can actually have notable impacts. The ad on the right from the American Cancer Society saying it's so sexy and showing this picture of more of this sort of androgynous person who looks like they're rather weathered, trying to demonstrate that, hey, this person is smoking and this is kind of the look that it achieves. So trying to utilize some of that stigma to dissuade people from using. We have a couple other ads, which this one is from France, or these few actually are from France. These aren't things that we probably would permit in America, a picture like that. But they're equating smoking around children to essentially suffocating a child. The caption says, "Smoking isn't just suicide; it's murder," and that's insinuating again the aspect of secondhand smoke on children and how it can be impactful. And then this ad is also rather risque from France, but it's equating smoking to sex trafficking and prostitution. And the caption reads, "Smoking is to be the slave of tobacco." That's what the French translation is. And so essentially saying that you're powerless to smoking and everything. These all can have sort of powerful messages and in utilizing them to the healthcare field's advantage, so to speak, in trying to dissuade folks from smoking or tobacco use. Though it can also be somewhat, marginalizing. If folks were to see this and they were to be smoking, and it could have the impact of like, hey, this is serious, I really should quit. Or it could also, lead them to experience some amount of shame and feel like that they can't tell anyone else that they're smoking, or they can't, come to someone for help, because they feel guilt, or they feel ashamed of what they're doing because of how strong these messages are trying to dissuade others. And then some folks may prefer to hide that shame rather than seeking help. So it's, is it, particularly effective in preventing substance use disorders? It's been used pretty widely in the anti-smoking campaigns, and we've culturally kind of even accepted that. And sometimes we're even applauding local governments that are increasing taxes on cigarettes and making them more difficult to obtain. Many states recently increasing the minimum age to purchase cigarettes. Health insurance premiums go up if for folks that are using nicotine products. Like all of these things are kind of like structural. These are examples of like structural stigma that we end up finding accessible in a way, as a means to enforce, the idea of reducing substance use. So it can be helpful in some sense from a larger public health standpoint. But there are also, times where we're trying to reduce stigma related to things, and it can have some harmful effects, right? So if we look at cannabis as one of the big examples of things that our general society has been trying to destigmatize, and it seems likely that the sort of polarization of how intensely people were either advocating for cannabis or detracting from the safety of cannabis, it seems like we were probably in a little too deep on either end. Though what we see from even reducing some stigma about cannabis, legalizing it, and having it available for medicinal purposes, even there have been a number of studies, most of them coming out of Colorado, them being the first state to actually legalize cannabis, where there are more and more children coming into ERs from unintentional ingestions, because there are more freely available cannabis products in the home. With the growth of dispensaries and commercial production of cannabis products, we see any number of ways to ingest cannabis, and there are bright, colorful wrappers and all of this kind of stuff that might be appealing to kids, not realizing that it's actually, a drug. And so we're by reducing that stigma and making things way more available, we have this sort of, there's risk in that as well. We want to try and destigmatize the idea of seeking treatment, and the fact that substance use and substance use disorders, can be a real condition which you can receive treatment for. Though there's some element of risk unintentionally, albeit with reducing stigma of a substance, just full stop. And I think as we're getting more learned as a country on cannabis, and it's becoming more widely available, I think we're being smarter with these sorts of things, and realize these sorts of risks. Though at least in the initial stages, I mean, there was a huge uptick in kids getting hospitalized for these sorts of things, and it had nothing to do with the structure or the legislation. It's not like kids were purchasing them, just available in homes and not secured. So, and this sort of destigmatization or reduction in stigma related to cannabis, it kind of begs the question, like, how did we get to that in the first place? Why did we have to destigmatize cannabis, and how did substance use disorders become so stigmatized in the first place? And to take a look at that, we're going to go back and go through some of the history of um, opioid use and our nation's first opioid epidemic. It actually began over 150 years ago, so it's not just a recency thing. We were seeing this as far back as the Civil War. Opium was one of the few options doctors had for soldiers that were injured that could alleviate some pain. The Union Army alone issued nearly 10 million pills of opium to its soldiers, and millions of ounces of tinctures and opium powders. There really was no alternative. Aspirin wasn't around until 1899. Penicillin didn't come around until almost 30 years later. We wanted to be able to help, and we didn't have too many options. We wanted something that would work quickly, and at the time, medicine was still not as well accepted as kind of the go-to. There were several other. We were more accepting of more alternative types of medicines, and people would go to healers or psychics and these sorts of things. They would go to them with more regularity back before medicine had really kind of planted itself as something that's pretty reliable and effective. We'd seen things like opium as more of a wonder drug, and they were giving it for just about everything. At one point, even prescribing morphine for like menstrual cramps or giving it to babies for cough and colic. At some point, we got to almost 1900, and opioids were upwards of 15% of all prescriptions. It was really rather remarkable how quickly these kind of things took off. And so these are a couple old advertisements for things that we would be using as actual products. And so Mrs. Winslow's soothing syrup, the two main ingredients in that were alcohol and morphine. And so it's listed, it's advertised as the mother's friend for children that are teething. And so we were going a bit overboard with all of that. I mean, that seems like a bit excessive for alcohol and morphine for a child that's teething. We wouldn't go that far now, but this is what we had then. And so we there was a good amount of overprescribing, and it's a little bit of overlay. I think the pictures got misaligned there, but in the quote says doctors who resort too quickly to the needle are lazy, they're incompetent, they're poorly trained, and behind the times. And that's in reference to using morphine or injecting any sort of opioids. But there was really no alternative at the time, and docs feeling a lot of pressure and understanding that there was some relief that folks would get from opioids, they continued to prescribe. By 1895, they estimated about 1 in 200 people were experiencing some sort of dependence on opioids. So that's pretty substantial. We're talking about at like 0.5% of the entire population of America, based on how many prescriptions were being doled out. It really was rather remarkable if we're looking at the numbers, especially compared to today. That's nearly triple what we'd had, in the 90s going into 2000. And so it's a pretty substantial amount. The picture here is referring to actually a child who is sleeping in the bassinet, and there's the parents are nowhere to be found. The caption reads that opium is the poor child's nurse. The typical person with an opioid addiction in this time was an upper middle class white female using opium, kind of neglecting the child because of how impaired they could be using something like opium. but it was something that was only really accessible by prescription, and it was something that was way more prevalent and way more uh, acceptable socially at that time. Um, though, as we're starting to recognize more of like the potential harm from all of this, uh, we get to our nation's first law related to drugs. Um, and so in 1875, San Francisco issued, an ordinance limiting any sort of opium dens. So we, as a country, our pharmacies would distribute morphine. It was considered to be somewhat separate from opium, and similar to how we currently view things like heroin versus prescribed opioids now. We were looking at opium as sort of like this less regulated, less safe sort of alternative that was going to be way more dangerous to folks and more difficult to regulate. So the ordinance against opium dens made it a misdemeanor to keep opium or visit any place where opium was smoked. They had the San Francisco Chronicle actually reported this, and they yielded this quote where it's the opium smoking establishments kept by the Chinese for exclusive use of white men and women and of young men and women of respectable parentage. Sort of like painting the picture that we have these otherwise respectable persons that are traversing into an opium den that's run by someone of Chinese descent, and that this made it as if they were being tempted by something that was evil, so to speak. It was something that's coming from a foreign country. It's something that's we wanted to sort of separate our ability to prescribe and regulate a pain medication from those that are just importing opium and almost painting the picture that they're taking advantage of upstanding citizens otherwise. And this this is a graphic from a novel in the 1880s, and essentially it was a series where they had it was billed as like having Chinese crooks and opium fiends, and this person was going to like shut all these down and beat the bad guys, so to speak. And the caption at the bottom it says, I'm going to rescue that poor girl from this den if I have to choke the life out of you two. And this was old King Brady, the person that was the main character in this sort of novel. And so it's pervasive into sort of the culture then, and it was recognized that opium was more of a Chinese byproduct and not something that we wanted to expose Americans to, so to speak. And this figure being a little bit more of a clear depiction of discrimination towards the Chinese population and bringing opium into the country. The sign on his chest says "Destroyer of Women and Children," insinuating that this person that was appeared as if he would be Chinese, which is what we affiliated the opium dens with, as being the enemy, someone that's coming after our most vulnerable populations. And so what ultimately happens with all of this, opium dens had taken on a lot of popularity, and there were more and more prescriptions of morphine. We see addiction on the rise, and pharmaceutical companies attempted to figure out, like, how can we get people away from these substances? How can we reduce our reliance on morphine? How can we reduce people recreationally going to these opium dens? And what's quite interesting about this is the response was the invention and the patenting of diacetylmorphine, which is also known as heroin. So heroin came around in 1898, which, if you recall, was just before the invention of aspirin, actually. and was touted as a treatment for morphine addiction, and also had an indication to be used for cough. So as we know, morphine's rather potent, or heroin's rather potent, far more potent than morphine. And so this took off in popularity really quickly, which initially was seen as an alternative, and we could get people off of these substances. So what we came to realize is that it was quite potent, quite easily abused, and we ended up having more of like an illicit market for something like heroin, not just via prescription. And so what we see is political action coming in, right? We have our first ordinance that starts banning opium dens. Then it starts to grow across the country. At this time, the U.S. had a lot of ambitions to colonize more overseas, and the Philippines were a territory that was under American control, and there was a lot of opium trade there, which raised concern. And so they wanted to start regulating that, though it was going to be difficult for them to regulate opium trade out there when they didn't have any sort of legislation themselves. So they ultimately, drafted a bill, sent it to Congress, and the idea behind that was to ban the import of opium and punish possession with up to 2 years in prison. And so, given the economic and political climate of the times, I mean, it passed swimmingly. Like there's no resistance. And this was in February of 1909, and essentially limiting the opium supply ended up driving up prices of pharmaceuticals, and even within the illicit market, things tend to be getting more expensive. And people started drifting towards more and more potent opioids, including heroin. As this was happening, what we see is there's a change in the face of what your typical opioid user would look like. Previously, we'd seen upper middle class white folks, and often mothers that are at home with their children. And then we have this article, this newspaper article in 1910, where they're referencing the Negro cocaine fiends being a Southern menace, right? And so it's a far cry from what we were seeing 20 years earlier with opium. And when they're reporting sniffing and a lot of these powders, cocaine at the time would be cut with a lot of these powders. And so we see that the population is shifting towards lower class and minorities at the time, and then later claiming that a lot of this had to do with prohibition, which comes later in the decade. So we also see soon after this, we have the Harrison Tax Act of 1914. And the act initially, it appears to be focused on sort of taxing, regulating all the importation and distribution of opium. It had additional impacts as well. Part of the act includes a clause that only allows doctors to prescribe opioids in the course of professional practice, right? Soon after, there was review of this act, and what they found was they did not consider professional practice to include opioid addiction. So, as of 1917, a doctor could not prescribe opioids to a person with an addiction because addiction was not a disease. And so the actual enforcement of this would have been imprisonment of doctors. So this led to a lot of change in terms of how docs were prescribing, as well as the sort of stigmatization within the medical community of if there was actually addiction, what could we do? We couldn't effectively treat. And so we were finding that folks that are using opioids not from a physician were essentially criminals, right? Like they weren't allowed to possess any of this. So they also couldn't come in for treatment because if the physicians were to treat them, they would themselves be considered criminals. And so by doing all this, I mean, it's not difficult to see like how this is going to turn out, right? We end up with having crime waves. There's a lot more illicit activity trying to pursue opioids and being able to maintain use. We have a lot more of it being smuggled in to the country. You have much larger organizations doing so, and what we saw, soon after this act is that the consumption of opium was actually increasing. So there was way more imported in 1920 compared to 1919. And it was essentially because there'd been all these restrictions, there had to be all these back channels and loopholes in order to get to provide the supply for those that wanted to use. And so it became such a large endeavor and such a profitable business that some of these places where some of these individuals had a more organized sort of distribution plan. So for those that don't recognize this person, this is Charles, also more commonly known as Lucky Luciano, who really was the ringleader in heroin as more of like an illicit substance and providing a street market for it. As well as he had a big role in prostitution as well, actually. This was most common within the Prohibition era, and that a lot of times they had been bringing alcohol or brewing alcohol, on their own and were profiting off of this, though they weren't really necessarily able to maintain that during Prohibition, and there was a lot more of a vigilant eye on. And so, heroin was lighter in terms of the amount that you have to use to obtain a high. It was more valuable than alcohol, and it was him also running a prostitution ring would use heroin to actually essentially drug females so that they'd be more easily exploited for prostitution. There was a lot of shady stuff going on, though compared to alcohol, it made a lot of business sense, and it was a low cost, very high potency, and the importation and distribution really, it really became a much larger scale because of everything Lucky Luciano was doing. And so that's, and the opioids didn't disappear between Prohibition and the 1930s and 1990 when we started to see an uptick in it. It's been present, though. There are a lot of parallels between that initial opioid epidemic and what we're experiencing more recently. And so we have initially what we were seeing from people that would be using morphine would be an ad similar to this one on the left, where we have this female who looks healthy. She's in a nightgown, like in like a comfortable bed with a headboard and like a fur rug down there. And then just a few years later, we have this picture of people passed out in an opium den with someone looking over them and kind of almost watchful. It's we can see how that would be such a contrast between those two sort of dynamics. Early on, when we have opioids, we see it's more of an upper middle class sort of acceptable thing. As we're progressing and there's more and more legislation against it, it becomes more of it's seen as more of a dangerous or illicit sort of activity. This ad here on the right, being far more recent, this is one of the pictures that's in an ad for OxyContin. And so Purdue Pharma placing this ad, you have this this older gentleman who looks like he's smiling, feels like he has almost like there's almost like beaming in a way, insinuating that use of OxyContin has given him like this pleased or pleasant feeling. And we have this picture also from the late 90s, where we have someone just trying to find a vein, trying to inject heroin, essentially. And so looking at this, we see that we have ways of sort of criminalizing or creating a negative connotation of certain types of opioids, right? With the opium den versus the morphine tincture. We have OxyContin that's prescribed versus heroin that this person's injecting. And in this dirty parking lot, he's looking unwell. We have these different ways that we're conceptualizing these things in greater society. And so, what that really tells us is that, there's an amount of race and socioeconomic status that plays into a lot of the way we perceive these things. And criminalization had such a huge consequence in terms of how we perceive it and the moralization of addiction and using substances in general. And this has happened with other substances as well. The Mexican communities and cannabis, and how there's the Marijuana Tax Act, or the Marijuana Tax Act. We have the Black communities and cocaine, and in the past as well, and more so now we're seeing cigarette smoking being associated with lower socioeconomic status and those marginalized populations. And beyond just the actual stigma, we have a lot of public health impacts that happen with criminalization of different substances. And so, this figure, although it's an older table, I couldn't actually find a more recent consolidation of all this data. But what we see is that between 1977 and 1990, the most prominent offense that got someone time in a state prison almost tripled, being related to drug use. And as of 2016, that number was actually 47%, not 32%. So about half of people that are sentenced to these federally funded prisons, their most prominent offense is a drug offense. In 2015, only about 15% of these people that were sentenced had to do with a violent crime. So we're seeing 3 times as many folks that are coming in for drug offenses as their most substantial offense. And so it's really putting a strain on the prison system. And about a third of people on probation and parole have a drug charge as their most serious offense as well. So there's a huge strain on the system in terms of actually managing the criminal aspects of these substances. And so what actual impact has it had? And what we've seen looking at these numbers over years, decades, it doesn't actually end up deterring any sort of drug use. We have like more of a drain on the budget, so it reduces funds that we can funnel towards actual like programs that might prevent drug use or can get people into treatment when they've already been using drugs. It's really not helping the individuals, and what we see is that within the communities, it can also be quite disruptive, at least initially. Incarcerating someone that's distributing, or like a drug dealer, we often see an increase in crime within those communities soon afterwards, where there isn't necessarily a prominent source for substances, or there's less of a clear hierarchy within those communities. It becomes more of a free for all. You have people within these organized rings that are taking on all these responsibilities, and there may be more, or there may be less less of a clear understanding of how things are supposed to go, and that often leads to like gang violence and individuals that might be less fit for the job, less stable, and then oftentimes leading to increasing crime, both violent and nonviolent, soon after incarcerating drug dealers. We also have felony convictions for certain substances that can make it so that it's exceedingly difficult to even get out of prison, as well as when you would being a functional member, a contributing member to society. Beyond all that, there's a huge difference in terms of financial drain on the system. The cost of treatment is about 20% of what we'd see for the cost of incarceration for a year, working with opioid use disorders specifically. So it's what we see when we're looking at these actual budgets, less than 2% of the budget going towards these sort of things is actually focused on treatment. We have upwards of 95% of it looking at the punitive parts of the legal system in terms of like incarceration and that sort of thing. It's upwards of $70 billion spent on incarceration, court proceedings, probation, parole, all that kind of stuff, just in those dealing with substance use disorders. So it's a substantial toll kind of on our society, on public health funding. And so what we'd advocate for would be more things like drug courts or alternatives to prison programs. We see is those sorts of things can be really helpful to folks, and there is some evidence for potentially decriminalizing use, where it can reduce any sort of violent crimes related to substances, or it'll certainly reduce things like jail time and folks going to prison for drug use. And we see in Portugal, I believe it is, where all substances have been decriminalized, we see far lower rates of actual incarceration. We see lower rates of things like HIV and hepatitis C, things that would be commonly associated with intravenous drug use. We see actually lower rates of the substances individually of being used. There's an initial uptick right after decriminalization, where their rates of use are higher, though years down, just a couple years down the line, even we're seeing lower rates than previously when people were having to use them illicitly. And within those regions, they actually are funneling a lot of that money into treatment, as opposed to kind of incarcerating these folks. Most importantly, though, is offering treatment during incarceration, and right around the time people are transitioning out of jails and prisons. And so there's actually, I'm pleased to note that this actual aspect of the presentation, I've given this talk for a few years now, and these numbers have actually improved rather recently. And so it used to be less than 1% of jails offering methadone or buprenorphine, Suboxone, and it used to only be 4 of the state prison systems as opposed to 20. So we're recognizing the utility in doing some of this. What we see with offering this sort of treatment for those that are in jail or coming out of prison is that there's reductions in actual, we see reductions in recidivism rates. We see people are more likely to stay alive soon after leaving. Right after leaving prison or jail tends to be one of the most risky times in terms of relapse, and relapsing after that period of time it can often be lethal, as we don't have the same tolerance or anything of that nature, and an overdose is way more likely within that time frame. And substance use is really common within those that are incarcerated. If we can keep them in some sort of treatment after they're leaving, if we're going to reduce the likelihood that they're going to return to jail or prison or commit some kind of a crime to obtain drugs or funding for drugs, it's a win all the way around. And so it's good to see that there are some there are many states that are kind of coming on board with this, though it is still less than half the U.S. is offering these sorts of things, despite the fact that we're looking at a savings of probably in the neighborhood of $90,000 for a community if someone were to be able to re-enter the community and be a functioning member, as opposed to the dream that's placed on our funding if they're incarcerated or returning to jail or prison frequently. So that's these are things that are systematic. These are things that can tend to be at a higher level than what we can individually control in any given day, right? And so what can we individually do to reduce our expression of anything stigmatizing or what have you? And these are a few steps from a toolkit created by the Addiction Technology Transfer Center, and they actually they have a nice list of things. We'll go into some of it for time's sake. We can't necessarily address all of these things. But first, we want to recognize our own stigma, and we'll get to that in just a second. Learn more, speak out, want to keep hope alive, treat people with dignity, and think about people as a whole person, right? And so, going about recognizing our own stigma, um, there's a nice there's a nice website that goes through our own implicit biases, and it's a large study that's put out by Harvard, and I'll have a link to it at the end of the talk. That can be helpful in terms of kind of recognizing our own stigma. Though a few questions that we'll ask ourselves, just sort of related to addiction. What our personal beliefs about why people become addicted. Do you believe that addicted people are weak, lazy? They can be immoral, maybe sinful. If you're someone that's in recovery, do you secretly believe that you're superior to others that are they're still struggling with addiction? Do you find that certain types of addiction are more acceptable than others? Um, you know, do you believe that addiction to an illicit substance is worse than something like alcohol or tobacco that's legal? Do you believe it's easier to recover from certain addictions more than others? Uh, do you believe that some people are beyond help? Um, some are doomed to a life of addiction. Some people never really get better. And do you believe that certain treatment approaches are better than others? Whether it's abstinence-based versus um, Suboxone per se, or is Suboxone better than methadone, or vice versa? Do you believe that recovery has to look a certain way? Is do we judge all of people's behaviors through the lens of recovery, or if you are in recovery, do you have judgments about other people's path to recovery based on your own experience? These are sort of conceptual things that we can look at related to our own internalization of the idea of addiction and substance use disorders, and sometimes having these sort of thoughts can kind of help us to conceptualize how we might view addiction or people with addiction and substance use disorders. And so, to touch on the rest of these briefly from this nice toolkit, I mean, learning more, you guys are already doing that just by being here today. There's a lot of accurate information out there about addiction and treatment. There's also some inaccurate information out there. There's a section with some further reading material at the end of the talk. You guys might find useful with that. Speaking out, not necessarily being quiet when you're noticing things like this, or particularly with misinformation. I think that's where we can do our most work, is when people have misperceptions about things like medications for addiction treatment, things like methadone, Suboxone, or Vivitrol, or what have you. Making sure that we're providing the appropriate information can really be a role for all of us. Keeping hope alive and understanding that addiction is a journey. It's a lifelong battle for a lot of folks, and to keep working with it, to keep trying. A lot of people end up in recovery, living happy, healthy lives, and sometimes it's periods of recovery and relapse. Being persistent, keeping the hope up, can be really helpful. Sometimes we're the only ones that are hoping for our clients when things are pretty low. They might not even have the hope themselves. So sometimes it's on us to help them with that. And treating people with dignity, thinking about the whole person, that kind of leads into a little bit of what we'll talk about with person-centered language here. And people are more than just labels. We want to make sure we're treating people with respect and not necessarily blaming or labeling or what have you. We want to focus on some person-centered language. There have been a few studies examining the perceptions of folks related to certain terminology in substance use disorders. So, we're really thoughtful about language in most of our day-to-day practice, right? Just as we're careful about the way we'll phrase a question or a statement to avoid leading a person to a certain response or to avoid upsetting a person, we can also be really thoughtful about the terms that we're using when we're talking to them or describing them to others and describing their condition to others. So a few of these terms that have been associated with the negative sort of implicit bias: addict, alcoholic, recovering addict, opioid addict, substance abuser. We'd prefer using terms like recurrence of use as opposed to something like relapse. We'd say pharmacotherapy as opposed to maintenance medication or maintenance therapy or opioid agonist therapy, referring to people as someone with a substance use disorder. That they're more than just an addict or having an addiction. They're a person with a substance use disorder. It's less derogatory, so to speak, than to label them as an addict or an alcoholic. And it's important to note that in particular, person with substance use disorder, it was actually still somewhat of a negative connotation, though markedly less so than using a term like addict or alcoholic. And in general, there can be some sort of identity for folks within, identifying themselves as an alcoholic, going to AA, like actually identifying with that community and presenting themselves as an alcoholic as sort of like a means of their own understanding and their belonging within a community. In general, if it's helping them with these sorts of things, I think it's still appropriate. It's still acceptable. I generally refrain from using the terms myself, in the sense that we're not trying to label folks. We're not trying to just kind of pigeonhole them into like this one thing. They are an alcoholic, so to speak. They're a person with a lot of characteristics, a lot of traits. They've got a lot of things that they're dealing with, and they have an alcohol use disorder, right? We're trying to make sure that we're not being derogatory, and thinking of them as a person with these difficulties, not defined by these difficulties. And so there's this PDF from the Substance Abuse Mental Health Society of America, looks at how we can go about approaching things with less of a discriminatory sort of approach and interaction, and kind of really helps to actually conceptualize a lot of these things. And so one of the quotes that came out of this is actually, I thought it was pretty salient. I put it on the slide: protesting any labels that turn people into things. So the words are important. If you want to care for something, you call it a flower. If you want to kill something, you call it a weed. And so that really can kind of affect how we might conceptualize things. Like if we're not using more thoughtful language, we might be inherently placing less value or more of a negative connotation towards someone or something. And I really liked this figure that they had at the bottom here, where we kind of have this sort of like rough conceptualization of how we go about assigning stigma or attribute fault or what have you for certain conditions. And so if the person has low perceived fault or control over what's going on, we wouldn't necessarily stigmatize those conditions. An example would be like we'd think of any sort of like medical condition that may fall upon a child, right? So if you have a 6-year-old that's hospitalized with an asthma exacerbation, it's like, well, he has no control over that. It's something he was born with. It's not really his fault if he was exposed to less clean air or smoke or something like that. Like if the parents should be protecting that child. So we wouldn't stigmatize the child in any sense. It's not necessarily their fault, or we wouldn't perceive them as having control over that situation. So where we get into trouble with substance use disorders is there's some perception of control and or fault for treading into those waters in the first place, for having tried a substance or what have you. And there's a perception of an amount of control over that sort of thing, that leads us to have more of a stigmatized view for it. And so it's a nice figure to kind of demonstrate the way, like the sort of spectrum in which we think about these things. And there's also, and I apologize for the picture, seems to be misaligned there too. There's an actual section of this Words Matter sort of series, which also has a podcast series associated with it. The power of perceptions and understanding. It's actually something that you can get CME credit for if you're actually completing like the whole podcast series and taking questions for afterward. People tend to find the sort of things a little more appealing to complete, as we all need continuing education credits. But it is actually, I've listened to it all. I thought it was actually conveyed quite effectively, and it'd be a good use of your CME if that's what you're searching for. And so basically, what it all boils down to is it's a few main points, like using person first language, like we just discussed, making sure we're not conflating substance use with a substance use disorder, right? Not every use of a substance or amount of use of a substance technically meets criteria for the disorder. And we want to make sure that we're actually being thoughtful about what is problematic use and what is just use of a substance. Are we using more of like the common speak or colloquial language as opposed to the more technical language with a clear meaning, right? We opt for saying things like it's a positive urine tox for cannabis, as opposed to saying the person had a dirty urine. I would hate to. I don't generally use the terms dirty or clean either, although some patients will say they're clean when they're sober. I would say things like sobriety or abstinence, as opposed to saying that's they need to get clean. Want to try and avoid sensational or fear-based language. We don't want to make things seem like newer, scarier, more prominent than they really are. We want to address things as they are, and that kind of leads into not perpetuating any sort of like panic or a fervor related to drug use or the morality surrounding drug use for some folks. So in short, we want to be watching our language, not defining people by their disorder or sensationalizing addiction or recovery. Honestly, it can lead to a lot of shame for those folks that struggle in recovery if we're describing them as superheroes and really going over the top with it. We certainly want to congratulate folks, and we want them to be proud of achieving recovery, like getting into recovery and maintaining it. We just want to make sure that we're supportive and not over dramatizing them. We don't want to generalize about folks with substance use disorders, and which kind of speaks for itself. And we also get into a little bit of trouble when we're using substance related terms as like sort of metaphors, like I'm addicted to chocolate, or the person's a workaholic. We don't want to detract from their experience and the significance that a substance use disorder can have. And quick summary, I know we're running short on time here. We see substance use working with addiction. It's one of our most stigmatized, if not the most stigmatized health issue. We have public health messaging, sort of media influencing a lot of the stigma surrounding these sorts of things. And if we look back at opioid addiction, it's frequently been related to race or socioeconomic status, and somewhat still is. That's part of the picture of how these stigmatized sort of conditions develop. And we can all champion this in a way. We can be advocates for it. And so it all starts with how we're approaching folks and how we're discussing the patients we're working with, and trying to do so in a more a more person-centric fashion, a more appropriate fashion, not non-derogatory. So with that, I'll open it up to any questions.
Dr. Wade, thank you for an absolutely remarkable presentation that's so thought-provoking and heartfelt. I just really appreciate your being here at Silver Hill with us, and makes me proud to be working with somebody with such thoughtful mind. So thank you, everybody out there, all 150 people tuning in today. Please feel free to put a question into the Q&A, and we'll get to those. We've got some right there, and Ryan, you can stop sharing too, and then we can just be a duo here.
I would want to put up, there's just a slide here for any sort of reading. I put QR codes next to these for those that are on a computer. You can scan it with your phone to go to some of those sites. They're good resources in terms of.
So we can leave those up for a minute so people can actually do that. I had a question for you. You made me start wondering about take-home naloxone, and so I started thinking to myself as you were talking, well, most of us are trained in CPR as required by our organizations, or to be good citizens, because if we come upon somebody who's having an MI or chest pain, we would want to know what to do. But it seems to me that take-home naloxone would be something that we'd all want to have in our car, in our glove compartment, should we come upon somebody who was non-responsive. But that's not kind of advertised. I don't know about kind of campaigns other than I know about some kind of programs that require that of post-prison and patients participating. Do you think that's a result of stigma? And if we were to all have something that we could do actually and take this on as a societal problem, would that be a way to shift our thinking about this problem? Or what are your thoughts about that?
I think in part it certainly can be, right? I think when we talk about CPR or something of that nature, it's training for something that we don't need a physical product for, right? And I think naloxone in and of itself, it would be something great for everyone to have access to. I actually carry some around in my backpack every day, and so it's something that is of little to essentially no risk to administer to someone if it's not going to be effective, and that's partly why it can be so safe. It can be. I'd advocate for it to be even more accessible. There are times where pharmacies have done programs where they'll donate some, they'll be able to give some away for free, or certain community organizations will have some that they can dispense. It really is, it's something that's life-saving. It's something that honestly could be included with sort of BLS training. I would think you find someone down on the street in any major city. I mean, you're probably just as likely to have someone that has had an overdose that Narcan would be helpful for as you would someone who's had a massive heart attack and could utilize CPR. We see it all the time, and it's literally life-saving with little to no risk attached. And that I've done the training course, and I've done like a train the trainer course. It's actually not that convoluted. It's something they could add into BLS training, for example, and wouldn't be too much of a heavy lift for the trainers. I think the fact that we're not there is probably because it requires a prescription in a lot of jurisdictions, as well as the fact that you need the actual product, the actual medication to administer it. So it's not as universal as using your hands to do chest compressions.
Right. Hey, do you want to take down the slides?
Sure.
Great. So Kenneth Berg gave us a few questions right off the bat in response to your description of the Harrison Act and the question of the response to restrictions, and was wondering things like, is that, he writes, is there a similarity between the increase in opium and heroin use importation after the Harrison Act to the increased purchase of guns following mass shootings due to concerns about restrictions? And conversely, any data about narcotic use in the Netherlands after legalization? And I guess the general question here would be kind of your sense about the response to restrictions.
Yeah, and so I think the fundamental difference between the initial question about people buying guns in response to mass shootings and that sort of thing is I think there's two major differences there. One being we saw this response to prohibition and the Harrison Tax Act and all these things after it was actually implemented. Where we see there's a lot more restriction and there's a lot more illicit importation and all these drug rings with gun purchases following some of these shootings. It's there's fear of legislation that will restrict these, and so they're trying to get in before this sort of thing would be passed. There's also an element within that of personal safety. Some folks will see an event like that and want a firearm to protect themselves, as opposed to worrying that gun legislation is going to keep them from being able to get one in the future. Whereas with the substances, if you weren't using, there's little risk to personal safety that might influence those sorts of decisions. So I think it's a similar concept. It's just a little different in terms of the timing and the additional safety element. As far as the Netherlands, I'm not as familiar with that data. I believe Portugal was the first country to do it, and probably where some places are modeling after. And so I'm a little more familiar with such a drastic reduction in their rates of incarceration for substances used, as well as overall reports of substance use and people engaged in treatment, reduction in costs, like public health costs. I'd have to look into what's gone on in the Netherlands. I'm not as familiar with that.
Got it. Yeah, thank you. Thank you. Cheryl Roundtree writes, Dr. Wade, do you have data or see trends related to the decriminalization of marijuana and the effect on our teenagers' use of the substance?
So we have seen increases in actual cannabis use from the adolescent young adult age range. I'm getting that from the SAMHSA National Survey on Drug Use and Health, which they do annually. So we've seen increases in that, in percentage of people that have used within the last month. The difficulty in trending, the actual impacts of that is that's more of a longitudinal study, and it's difficult to control, for anything that would be confounding when we're looking at large scale data like that. But we have seen some increases in the last decade or so in terms of cannabis use within that younger age range, presumably, at least in part, due to all these states that are decriminalizing or having medicinal cannabis as well as recreational use of cannabis. But the numbers are trending up.
Thank you. John Allen writes in, would it be fair to say that stigma plays a major role in preventing politicians from legislating in a way that would prevent ineffective responses like incarceration and promote effective responses like treatment? Not having a politician weigh in on this, I would suspect very much so. That's sort of what we see with the pattern of these things, and it's not often that legislation is as up to date with the medical literature and how we go about treating things, and they have to be informed by the medical community, but they're not always as up to date as we are with things, and they have plenty of other things that they're looking at. There's also sort of like this overall perception of a lot of those substances that they don't even really entertain many of those ideas. So the fact that a lot of these state prison systems are now offering things like Suboxone or methadone, when just a couple years ago they weren't, I suspect that they were having a little more traction with legislation than we previously did. Though I think that's a huge part of where these things come from in the first place, and then things in government tend to be slow to change and based on historical precedent. So there's a lot that factors in, but I do think stigma is a big part of that. Like when we're looking at the perception of if a legislator was to propose this bill, how they'd be perceived by voters and those that carry some of this perception or the stigma towards substance use disorders. Great. Someone writes in anonymously, Dr. Wade, have there been studies on effectiveness of prevention campaigns, particularly among adolescents and young adults? Is language changing in terms of prevention?
So, I think we're certainly more thoughtful about the language. and at least as you know, a healthcare and mental health care community, we're being more thoughtful about language. You know, the last, large scale sort of public health effort to reduce substance use or to prevent substance use disorders, the DARE program actually ended up, not demonstrating much in the way of efficacy. So I think there's still some work to be done in terms of what we can find from a prevention standpoint that can be effective. What we see from these countries that have decriminalized and variety of substances and are putting a lot of that money into treatment and prevention in a way. A lot of the prevention is secondary prevention, trying to prevent any sort of medical complications like doing needle exchanges, providing sanitary supplies. There's a lot of that out there that has some good evidence behind it. There's a lot that's still a work in progress in terms of preventing substance use and the disordered use of substances. Though what we see from those communities is a lot of that money is invested into treatment for those that have gotten to that point, and it's still costing far less than the incarceration and using the judicial system to discipline them, so to speak. So a lot of work to do on prevention, though it is still reducing costs of care and improving outcomes of folks they have on treatment, specifically in prevention of associated conditions that can come up with certain types of substance use.
Great. Dr. Wade, you have many a fan out there who have typed in their appreciation and joy in knowing you. So make sure to look at the chat before signing off here in a few minutes. And let me read from one of them. That's head of our clinical services, Dr. Michael Grote, who says, I share Dr. Katzman's pride and joy in having you on the Silver Hill team, and I have a better appreciation for the compassion your patients experience when working with you. And you unpack more of the debates around control. They appear to run throughout so much of healthcare, where we talk about controllable lifestyle factors that lessen risk for cancer on the one hand, and then recognize the actual development of cancerous cells as outside conscious control on the other.
Yeah, and so there's, and by and large, the reference to control, like throughout this sort of presentation, it's our perspective of control that the individual has over all of this, right? So not having personal control over developing cancer of certain types, though we probably would have a different perspective of someone who's in their 80s and smoked cigarettes for 60 years and developed lung cancer versus, a child that was born with a brain tumor, for example, right? Like we would perceive those somewhat differently. And so the concept of our own control within what it is that we're suffering from, it does influence how we perceive it. Now, there's some amount of control or choice or free will, if you will, related to substance use and disordered substance use, and it's we see it more now as a disease and more of like it's an all-encompassing sort of thing that we're trying to treat, not solely a matter of choice and like this willpower against this one substance. There is still an element of control. There's a choice to go to treatment. There's a choice to go to these meetings. There's a choice to take medication or continue in therapy. There are choices. There's control in a lot of this. So it's I think the general perception of the disorders as a whole are that there's a lot of willpower and a lot of choice that goes into this. When we know there's an amount of physiology and an amount of like emotional distress that can really prompt some of these things that aren't as firmly in our control as some people might think.
Great, thank you. I'll just conclude here by Dr. Gerber's response, who says, I'd like to add my name to the growing member list of the Dr. Wade fan club. Thanks, Dr. Wade, for your clinical work, your scholarship, your camaraderie, everything you do for Silver Hill. So, Dr. Wade, thank you so much for really a beautiful presentation. And today, I think so much more that we can talk about, and couldn't quite get to all of the questions, but do take a look at, there's a lot of people who want to appreciate everything that you're talking about today and want to connect. So in conclusion, thank you all for joining us today. For a reminder, anyone wishing to receive CME and CEC credits, please complete the evaluation survey that will automatically pop up in the browser when this webinar ends. And I always like to say, we're connected up in 150 of us through this platform, and then now we're going to be back in our isolated rooms. So great to see you all. Thank you for being here today. And the chats keep coming on in, so take a look, Ryan. Thanks again, and we'll see you next for Dr. Fry's presentation. Stay well, everybody. Bye-bye.